22nd, we will be live on podcast. And this will be across our multiple media and on YouTube. It'll be available. We will send you the link. And we will be live on podcast. Okay, well, thank you very much, Dr. Musa. Platform is yours. Please go ahead.
You can see the presentation?
I do.
Okay. Good afternoon. I am Dr. Ali Musa Khalil. I am neurosurgeon. It's my pleasure to be with you today in this valuable and great meeting. And also, I want to thank the organizer committee for this invitation. Since we are talking about minimal invasive surgery techniques, UB or unilateral biportal endoscopic spine surgery, it is one of the trend technique developed in the last 10 years, and every year it's be more popular, global and popularizer and interested by the spine surgeon. UB, I don't think UB is just a new technique. Most of us, we are started our career and experience by traditional open surgery, big wound, extensive damage to the muscles and bones associated with the severe back pain post-surgery, long time for recovery, and after that introduced the microscope, which solved big problem and solved a big part of this problem. But still, all we know, we have demand for the better visualization. Still, with the microscope, still we cannot see everything in the best view like endoscope. So yet, I think the UB is responsible for this demand in the open and the microscopic surgery. It's not different than microscopic surgery. For this, the UB, it's more easy for the surgeon who's familiar with the microscopic open spine surgery. UB is combined of the it is surgery of the 2 port instead of the 1 port, and it's 2 days is used for the lumbar and cervical and thoracic degenerative condition and fusion fractures, and every is the indication extended more. And since I saw in the this year in the conference in the Europe, they told our short cases of the intradural spine tumor as well. Yes, there is a few trials, some few cases, but every is with the advanced surgery would be the surgeon more expert, the indication also expanded. When you look to the historical deployment of this surgery, we can show the 2 portal surgery start in the 1996, but as professionally the popularization of this technique, or now in this technique as we know it today as UB, is developed in the 2016 by 3 pioneer Korean, South Korean surgeon. And one of the famous or pioneer of this field today is Dr. Sang-Kyu Son, which is developed important steps and this surgery and created the space known as the Dr. Son space. So the surgical principle of the UB is like other spinal surgery. It's prone position surgery, placement of the 2 port instead 1 port, one for the camera and second for the working channel. Third, use the arthroscope, which is not specific for the neurosurgical approaches. It's used in the knee surgery. And another point which is very important and make this different than knee surgery, working space creation. Since in the orthopedic now this better than me, in the knee surgery there is space. There is no need to creating new space. But in the spine we don't have like space, so we need to creating space which is known as zone space in posterior approaches. And another important point in the UB is continuous saline irrigation, which is important to control bleeding and to get the better field. Technical advantage of this approach, it is minimal invasive, reduced muscle and soft tissue damage, wide field visualization, which make contralateral decompression more easy even than microscope. And another advantage of this technique, it is we can use the standard spine instrument, which is less cheaper and it's found in all the centers of the spine or neurosurgery or orthopedic surgery. So we don't need all the time to buy the expensive instrument like monoportal surgery. At this point, preserve facet joint stability and less radiation exposure compared to other minimal invasive approaches. We have mainly two approaches in the UP for lumbar spine, paramedial approach or interlaminar approach, and second paraspinal approach, or it's equal to the transformer approach in the monoportal surgery. Indication of the paramedial approach is mostly used for central and lateral stenosis, paracentral and migrated lumbar disc herniation, contralateral foraminal stenosis, and also fusion as TLIF surgery. Technique, it is interlaminar window access. The important point, triangulated of instrumentation. Third, continuous saline irrigation. Advantage of the surgery, bilateral decompression by unisite, facet preservation, and it's good for multiple level cases. Paraspinal approaches is more indication for foraminal and extraforaminal disc herniation, L5S1 far out syndrome. As technique is muscle splitting lateral corridor, direct visualization of existing nerve root, and limited SAP damage. Advantage of this surgery, direct root access, minimal facet injury, and safe for far lateral pathology. This is the comparison between two approaches. I mentioned this point. The key concept is pyramid is master triangulation, avoid instability cases, irrigation control. Paraspinal, it is anatomy and knowledge, need to better knowledge to the anatomy and to be limited the SAP removal. When you started the UB, we need some important point. First, to decide which approach is more practical or more indication. So for foraminal or extraforaminal approach, we cannot apply paramedian approach. And for central canal stenosis, we also cannot apply paraspinal approach. For this, we should be first now the indication. Second, when you start, there's some steps. First, the position of the patient in the prone position, as I mentioned before. Second, to creating the two-port, and the important point when creating the two-port, the triangulation of two side instrument. That's very important point. This is the setup of the patient. This is the drill. This is the RF. How you do our how you creating our portal during the paramedian approach. First, when you started, we should be draw first the midline incision. Second, we draw the second line, which is 1 to 1/2 cm lateral to the midline, which is medial to the pedicle lines. Third, we need to draw the interdisc space, so we draw 3 lines. After that, we need to create the portal location, we can choose in the disk space 1 cm or 1/2 cm above and 1 cm or 1/2 cm below. But another technique we can apply, we can create the upper port below the pedicle, and this is for the camera as camera portal, and the second portal for the working channel we can draw that through middle of the lower pedicles. And the important point, the hours target. The hours target in the paramedian, it is junction of the spinal process and lower lamina of upper vertebra. So this area, generally in the upper lumbar, the middle of the transverse process is accepted as the hours target, but for lower part like L5, S1, L4, L5, this we can go a little bit down. So this area, junction of the spinal process with the lamina, is our target. So our both the triangulation of our instruments should be towards this target point. But the important point, when we inserted our instrument, first we start by insert or created the working channel. There is some surgeon start by creating the camera or scope channel. There is no big difference. You can do which one you are familiar or learn in your training. It's not make big change. But important point, when you first time when you insert your portal channel, working channel, sorry, when you're creating the port, when you make your skin incision, you can, if you are in the beginning of this surgery, you can do longitudinal skin incision. But when get the experience, you can do the standard one, which is transverse or horizontal skin incision. But in the beginning, why it's why it's better to do longitudinal skin incision? Because if you are failure in the doing entrance or doing the surgery, you can convert the surgery to microscopic open surgery. So when you're creating your port, a skin incision, the skin and fascia should be sharp incision. After that, there is weak area. There is area between two multifidus muscle. This area is our target to go through by dilators. So we should be avoid to go through the muscle. We should be choice or found this area between two multifidus muscle, and this area is known as Son's space. At the end of this area in the spinal process lamina junction, this is area known as Son's space. This is space, we're creating the space. After that, by the pressure, hydrostatic pressure of the fluid, this make more pressure. So when you insert our instrument first time to creating this channel, we should be separated caudally and cranial and caudally and medially and laterally to create this space. And after that, when you insert the second scope channel, we should be do this angulation in the below. This angulation is very important to be sure there is good output of the fluid. We need to do this angulation, as I will show you in this one. We need to do this movement to make our angulation, and this make output of the saline is better. So this mandatory to create the our space and do this triangulation before starting the surgery. Because before starting the surgery, we should be sure the output of the fluid is good. It's enough to prevent any complications and to control the bleeding. Another point regarding the irrigation. We can use the pump or use the gravity pressure. The most safe is to use the gravity. The distance between the back of the flute and the patient should be around 50 to 70 centimeters. It is from the back of the patient to the back of the flute, and the the use of the pump all the times, it is not safe, because if increase any intracranial pressure, the possibility of increased intracranial pressure is more common. And another point is very important. The one of the complications of the UB is in the duratear. And regarding the study, the duratear is when there is duratear, the intracranial pressure injury happen more commonly if the hydrostatic pressure is high. So use the pump is not all the time safe, especially in the beginning. For the beginners, it's better to use gravity pressure than use the fluid pump. This is the case of the left side paracentral disc herniation. This is how you start. When you start the UB first, the image general is like this. You can see it's not so clear, and there's many times there's high bleeding. So many times you need to control this bleeding. To control this bleeding, you need two things. First, a good outflow of the normal saline or fluid. A second, use the RF. The RF, sometimes the bleeding, because it's very obvious, you cannot control. There is some point like 9, 6, 5. This point is more bleeding come from this side. If you cannot control, you can blindly control this area more sequentially, so to help you to control the bleeding the better. Another point, when you insert inside, there is important point to start your work. When you insert inside the space, the important point is the spinal laminar junction. Spinal laminar junction of the upper vertebrae. So you first time you should start to drilling this area. You can start first by drilling. After that, you can also use the Kerrison. For drilling, you can use a shaver or diamond. For beginner, I advise to use the diamond. Is more safer regarding the drilling. And the drilling should be start till we see this area of opening of the ligament flavum. And this area show us this, we are in the upper limit of our drilling. For more than this, drilling is not safe. This make weakness and risk of the fracture of the lamina. And this continuous of the surgery of this case, drilling of the spinal lamina junction. This is spinal lamina junction. Yes. Now this is the opening of the ligament flavum. If your case is just simple disc herniation, we can just remove part of this ligament flavum in this upper part. After that, start to do discectomy. If it is simple disc, this is the minimal invasive one. But if there is more aggressive disc herniation or migrated disc herniation, it is better to remove the upper drilling and removed by Kerrison the lower part of the lamina. After that, extended to medial part of the facet, and after that, drilling or use Kerrison or chisels you can also use to make a laminotomy in the upper part of lower vertebra. So at that time you can remove the ligament flavum better, since the ligament flavum it is two layer, superficial and deep layer. In the superficial layer in the lower lamina, it's insert on the dorsal of the lamina, and deep layer insert in the deep in the ventral of the lamina. So you can separate the superficial ligament flavum very easily under endoscope from the deeper layer. So many times you need to remove part of the superficial layers to help you in dissection, especially when you go to doing contralateral sublaminar decompression. After removing this part of the lamina and retraction of the ligament, you can see this very small area. You can insert inside and found the disc. This is the disc. You can remove the disc. Very important point to keep this epidural layer intact, because this play big role in the prevent of the fibrosis in the futures. And this is after removal of the disc. This is space, very small area. It is just around 2-3 millimeters. Another approach in the lumbar, it is sublaminar decompression, which is it's very important in the UB for decompression of the spinal central stenosis and lateral recess. In this approach, there is two approach, N and Z technique. N technique is the old technique, Z technique is new technique, but there is no big difference between both. In the N techniques, you start the drilling of the ipsilateral lamina in the junction of the spinal process with the lamina in the lower lamina of the upper vertebra, and after that extend the drilling to the medial part of the facet and lower and upper lamina of lower vertebra. And after that, you go to the other side to drilling the contralateral side. And this is known as N technique. But the new technique is Z technique. You start to do drilling on the ipsilateral on the side of the portal, and you remove the lower lamina of upper vertebra and continues the drilling till you've found the opening of the between two ligament flava, and extend it to the other sides. Complete your drilling to the other side, to the contralateral side, and after that you this is the like Z, and after that you go down to the side of the port and continue drilling for lower lamina and continues to the other sides. Important point when you're doing this drilling, during this drilling in the base of the spinal process, because the base of the spinal process they obscure the vision of the scope. So when you are doing this drilling, you can make space. And the important point, another technical point, you should keep the ligament flap intact during this drilling till you finish all the bone working, After that, you can start to remove the ligamentum flavum. And if there is severe stenosis, in case of severe canal stenosis, you can remove superficial layer of the ligamentum flavum and keep a deep layer to protect the thecal sac. This is shortly what I want to say about the paramedian approach, which is very important and useful now. And second approach is paraspinal. I will not talk about that. Just I want, because the time is will be finished. I just want to talk about another approach or indication now in the cervical: biportal endoscopic posterior cervical foraminotomy and discectomy. The indication for cervical foraminotomy and discectomy is cervical radiculopathy due to foraminal disc herniation or stenosis. Contraindication: central disc herniation, cervical myelopathy, cervical central canal stenosis, instability and infection. How you started this? Our target of the portal is pedicles, upper and lower pedicles, and should be the triangulation towards the V point. The V point, which is upper of the V point, is upper lamina, and lower of the V point is lower lamina, and junction of that, which is the medial part of the facet. We start the drilling of this, and after that we start to remove our ligamentum flavum and remove the disc. Second, another approaches, now also it's mentioned, I don't familiar with this approach, but it's mentioned now in all the books, the cervical laminectomy by interspinous approach instead of the sublaminar decompression, because it's accepted as safer than contralateral sublaminar approaches. It is indication for 1 to 3 level cervical canal stenosis with the myelopathy, segmental or localized ossification of the posterior longitudinal ligament. Contraindication if there is more than 3 level of stenosis, if there's severe continuous posterior longitudinal ligament ossification, and central disc herniation, instability, and significant kyphosis. This is bilateral decompression through a unilateral interspinous rod. Use drilling of the spinal process base to achieve space for contralateral decompression. It is the docking point, which is the upper part of the caudal lamina instead of the upper lamina, and the two skins are approximately 3 centimeters apart, and the center is the upper part of the lamina at the midline of the proximal and distal pedicles. So this is the docking point. It is the center at the upper part of the lower caudal lamina and in the midline between the proximal and distal pedicles. Clinical outcomes of the UB is high success rate in lumbar disc herniation and spinal stenosis and spondylolisthesis, and low complication rates, 6% for cervical posterior foraminotomy, rapid recovery, short hospital stay, quicker return to activities, and comparable or superior functional outcomes regarding other MIS approaches. Regarding the complications, the durators accept the most common tier. The complications is around 1 to 4. Generally, the tier less than 5 millimeter or around 3 millimeter is not need to convert to the open surgery. Just put some sealing material like taco sheet inside the opening area. It is in the most cases and enough and not need any another intervention. Nerve traction injuries, another problem. This could be because of the retraction during the manipulation, and another cause of the injury is high hydrostatic pressure because the high flow of the fluid. For this, avoid use the pump most of the time is actually more safer. Hematoma, another point. Infection, still there is infection, but regarding the microscope and traditional surgery, it's accepted 10 times less. Most complication managed conservatively and with minor revision surgery. Prevention is depending on the meticulous dissection, control fluid pressure, proper extractions. And thank you.
Well, thank you so much. That was an amazing talk. And I can tell you, I learned a lot myself, especially about that sun space. I think it was really time for somebody to find that space that this kind of surgeries are done. And I have actually a few questions, but I before that, even, I like to as well, talk about why is it spine the last area, one of the last area in medicine we endeavor in the endoscopy? As you mentioned very rightfully, I'm going to, if you don't mind, if you unshare your screen, I want to share one slide here with you so that really visualize exactly what you said about that there is no natural space in the spine, okay? So, and that is, this slide shows us that what I mean by that. Are you able to see my screen?
Yes.
Well, we
Yes.
know for almost 100 years, general surgeon, they put a tube, literally you used to put a tube and later on scope in the mouth or in the rectum to look inside, because there is a large opening and a large cavity. And then obviously OBGYN, there's a large opening, there's a large cavity. And then in about 40 years ago, urologists started using, when the optic got better, again, there's a small opening, but a small cavity, natural cavity. But as you said, in spine, there is no natural cavity and there is no opening. I think that is one of the things that we are struggling to catch up with the rest of the surgical fields. But I think what as well is important, what you said, is that we have to create a cavity there, as you described. First, you create the cavity, and then with the hydrostatic pressure, you maintain that cavity. Now, I want to ask you, you're a neurosurgeon, and I'm a neurosurgeon. For last 40 years, we neurosurgeons, we have been using a microscope, and every tool has its own advantage and disadvantages. And I will comment on that as well, but I want to know, compared to the macroscopic tubular decompression, what are the strengths and weakness of each approach if you compare macroscopic to UB?
Actually, regarding the tubular microscopic surgery, yeah, it's also accepted as a good approaches and it's with a good outcome. But during the tubular microscopic surgery, we can compare the tubular microscopic surgery more with the monoportal surgery, since you working through the one channel, so your view it's limited. But the UV is more comparable with the open microscopic surgery. You can control the field as well in the inside. So this is the different. I think the monoportal is instead of the tubular microscope, and UV is instead of the open microscope surgery. And for this, who's familiar with the open microscopic surgery, they will not found the UV is very difficult to apply. Just the big problem is the drilling inside the field, need training more, and another creating the ports. So if the creating the port is wrong in the beginning, or if you doing different opening inside the muscle, this make your surgery more challenges. The outflow of the fluid will be more problematic. So it make all this difficult for your surgery.
Well, yeah, I like really your analogy to uniportal versus biportal. And I think one of the advantage of the endoscopy as a general is that you don't have to look straight. You can look around the corner with the angled endoscope, but as well, that adds to the learning curve, because most of surgeons are trained to look straight at something. Now all of a sudden you have to retrain your brain that what you are looking is not a straight shot at your instrument, it's around the corner, which is both advantage, but then in the learning curve become a little bit of a challenge. I think additional advantage of endoscopy as a general is that, especially when you use the what we call thoracic cases, that you can really minimize the approaches with the endoscope, the opening size of the opening and so on. Those and with the macroscope has been overall very challenging to go long throw. And as well, as we all know, Dr. Parviz Kamin, who described the endoscopy through the transcambine approaches, used it exactly extraforaminal transcambine. Macroscope are not the good tool for that. They're really poor tool to go extraforaminal. All instrument or the throat, the focal point and so on, it become really difficult. So these are the advantage of the endoscopy. But as well, I'm going to tell you what are the advantage of the tubular macroscopic, where you can use both hands for the instrument, and as well you can truly with the macroscope bring the axis of your eyes closer to each other, and it enables you to look actually 3D on the bottom of the tube. So these are, so I think as a neurosurgeon, we have been familiar with the macroscopic one, but certainly endoscopy add tremendously to our toolkit. And then everybody has to, be able to have both ways, and then weigh in his or her own hand what are the advantage of and disadvantage of each individual approach. But it was amazing, and especially I like the idea of creating.
Excuse me, and now there is new trials. They try to use the monoportal instrument in the approach of the UBs. So used in the camera port, the monoportal endoscope instead of the arthroscope. So they use as scope and as the port as working channel, and use the working channel in the UB as another port for instruments. So I think in the futures will be we can use two hands inside the scope.
Excellent.
Yeah, behind the scope. Sorry.
Now, do you ever use some retractor system to hold the endoscope, so you can use?
Yes, I forget this point. It's very important, especially when you create your port channel working. It's very important to use semi-tubular retractor. It's very important to make the outflow of the fluid is better. So it's very mandatory, and this retracted the multifidus muscle laterally. This one. During the surgery, you need a retractor to retract the nerve root. And in that time, you need your assistant to hold the retractor to during this point.
What about those pneumatic retractors that are really very versatile, that they can hold either your endoscope or another tool? What kind of, if you don't have an assistant, or in a situation that you want to use a retractor, how, I would say, first of all, how often do you use a retractor? And if you use a retractor, what kind of retractor? Is it connected to the bed? Can you elaborate a little on that?
No, there is normal retractor, but it's more specific for the UB. When you buy this, you use the normal set of the spine surgery, but you need to buy also RF for this surgery, and buy the small set which include the dilators. There is Indian knife for opening the disc, and there is some retractor specific for retraction of the nerve. And also you need to get the semi-tubular retractor. This is special for the UB. You need all this also.
Got it. Well, thank you. That was very enlightening. Thank you very much.
Thank you for all you.
Yeah, great. Please join our society. We have a lot of endoscopic, experts in India and around the Middle East, and as well, I think we have a few good partners in Iraq. We are hoping to have a conference actually in Iraq within the next year. I hope that we meet in person. Okay.
My pleasure. Good.
Well, thank you very much. So we have.
Thank you for your attention.
Thank you. We have Dr. Darmul Mehdi. Dr. Darmul, very nice to meet you.
Thank you. Nice.
First of all, where are you located, Dr. Darmul?
In Tunisia, in Sousse, in Tunisia.
Excellent. Wow, what a beautiful
Thank you.
place. What a beautiful place. I have
Thank
you
you.
on for a comparative study about the minimal invasive versus
Yes,
open.
yes,
And,
yes.
any further ado, please go ahead. The floor is yours.
Okay. Thank you very much for your kind invitation. I am happy to participate to this session. I will share my screen now. I will put on full screen. You see? You see it? It's okay? Is it okay?
Yes, we can see
Okay,
the screen.
okay,
It's very
Thank
good.
you, thank you.
okay.
Yes, I will talk about.
Thank
I did a comparative study between UBE, microdiscectomy, and open standard technique for lumbar disc herniation. It is a recent study. You know that lumbar disc herniation often lead to nerve root compression and debilitating symptoms such as radiculopathy and low back pain. And the first line treatment is conservative, with including physical therapy and pharmacological intervention. And when this measure fail to alleviate symptoms, surgical intervention becomes necessary. And actually, traditional surgical approach, such as open discectomy, have been largely replaced by minimally invasive technique. And minimally invasive technique aims to minimize tissue damage, reduce pain, and speed recovery. Here we did recently a comparative study between the three technique for the disc lumbar herniation, lumbar disc herniation, and between January 1 January 2025 and 31 of March 2025, I operated 50 cases of lumbar disc herniation by these three technique, 18 by UBE, 16 by microdiscectomy by tube, and 16 by open discectomy standard technique. And I have compared the clinical result with the visual analogic scale, ODI, Western Disability Index, the length of incision, the length of operation, blood loss, and hospital stay for all these technique, for the three technique. And here we did 18 operation for lumbar disc herniation by UBE, 16 by tube microdiscectomy, and 16 by open technique. And we have more male than female, especially, but in open technique we have more female. The median age is approximately the same, 36 year for UBE, 42 year for tube, and 44 for open. There is no statistically difference statistic. And the level of lumbar disc herniation, we have more L5S1 disc herniation in UBE, more L4, L5 in tube, and the equal number for the open technique. There is no obesity. Our patients are not obese for the three technique. And the work later, almost all patients had hard work in the three technique. And the socio-economic level, we have in open technique, we have more low socio-economic level, maybe because the patient cannot afford money to pay the consumable instrument for used in UBE in tube, especially in UBE. Here, the visual analog scale for low back pain in preoperative is severe for almost all patient in UBE, in tube, and in open. And also a visual analogic scale for leg pain. Also for our patient is severe. Most patient had severe visual analog scale for leg patient in UBE, tube, and open. ODI, Western Disability Index on preoperative, most of patients in the three technique have also had severe ODI. more than 8 in almost all cases, almost. And here we compare the length of skin incision. The shortest length is in UBE. We have the short skin incision in UBE, then in tube, and in open we have 60 millimeter. The quantity of blood loss, we have no blood loss in UBE, a small amount in tube, and in open, the median quantity is 120 milliliter. The median time of operation in UBE, we had 120 unit, in tube 60, and in open 80 unit. The least time is in tube by microscope, maybe because we are familiar with the microscope. The post-operative hospital stay, the UBE group was discharged at the same day surgery. For the tube, 1 day after the surgery, and in open, the mean post-operative hospital stay is 2 days. Here we compared in the outcome the preoperative visual analogic scale for back pain to the post-operative. We have improvement, especially in the post-operative day 1, improvement in the back pain for all group, and especially for more in UB and the tube than open. Here for the leg pain, also we compared the visual analogic score. We have improvement in all group, but more in UBE and the tube. We have more improvement, more especially in the first operative day. Here we compared also the preoperative ODI to the postoperative ODI. We have also improvement at 1 day, 15 days, and 3 months for all group, but more in UBE and the tube. And the result of our study, both UBE group and microdiscectomy with tube group had short skin incision, low blood loss, and early postoperative pain relief with short hospital stay, then open discectomy group. There is no statistical difference between UBE and microdiscectomy, and no complications seen for the 3 groups in the study. This study concludes that both minimally invasive technique used for lumbar disc herniation, such as UBE and microdiscectomy with the tube, are more effective than open discectomy, showing advantage, especially for early recovery and for functional improvement. Here I will show you one of my case, illustrative case. 32-year-old man, electrician, fall from 2 meter height, complaining with low back pain and left L5 radicular pain, not improvement by medical treatment. And here the imaging showed L4, L5 right disc herniation. We operated him by UBE, and here a short video showing the operation. Here, after entering, here we are removing the soft tissue to expose the inferior border of the lamina of L4. Here we expose the inferior border of the lamina of L4, and we will drill this to detach the ligament flavum. We'll drill this inferior border, starting from the spinolaminar junction to the laterally. We are drilling here the inferior border of the lamina of the L4 to detach the deep layer of the ligament flavum. The superficial layer was removed with the soft tissue. With the diamond drill, we are thinning the inferior border, and we will complete with the Kerrison. Yeah, we try to detach the ligament flavum from the inferior border of the lamina of L4 in the right side. We can use rongeur also to remove the soft tissue to better expose this area. We can complete after thinning this inferior border, we can complete with the crescent to reach the end of the ligamentum flavum, insertion in the ventral part of the lamina. We complete this resection with the crescent. And we will detach the deep layer of the ligament flavum to expose the dura and the nerve root. The field is very clean. Then the microscope, no bleeding. Because of the saline, here with the hook, we can remove the deep layer of the ligamentum flavum. I think the visualization is good than the microscope. I will show you after with microscope. I think here and the field is clean than the microscope, very clean. We remove resect the ligamentum flavum, the deep layer. We see the dura. We will start to see the dura. We complete the resection to better expose the dura and remove the soft tissue and some fat by the rongeur. Here we expose after exposing here the disc herniation, after retracting the dura and the nerve root, the disc herniation, and we'll do resection of the herniation. We can do hemostasis with radiofrequency probe. Here we will resect the disc herniation. Here the disc is removed with the disc forceps. We complete the resection of the disc. And here the root is free now. The root is free. Okay. You see here the incision, small, very small incision, and the disc herniation, and a short video the same day, 3 hours after the operation, the patient can walk without any pain, no leg pain, no back pain, and he was discharged the same day. Here another patient, Najah, 50 years old mechanic, complaining since 3 months of right S1 radicular pain, not approved by medical treatment. Visual analogic scale was 9 before operation, and with severe spine syndrome, tight lasag, and this the imaging showed right also, but L5S1 disc herniation operated by UBE with a good result, and the patient was discharged the same day. Now I will show you a case operated by microdiscectomy by tube. She is a 36-year-old female, work in a factory, complaining of low back pain with severe left L5 radicular pain, not improved by medical treatment since 6 weeks. And here the imaging showed L4, L5, disc herniation, huge disc herniation in the posterolateral, in the left side. She was operated by tube, by microdiscectomy, and here I have a short video of the operation after putting the tube matrix here with microscope. We are removing the soft tissue here. We are drilling the inferior board of the lamina of L4 to detach the ligamentum flavum. The same steps. This is the ligament flavum, the exposition of the ligamentum flavum. We'll detach it. We continue with to remove this lamina with the Kerisant. And we remove this deep layer of the ligamentum flavum. Here, and we are exposing after removing we see the dura, and we continue to remove the ligamentum flavum. We expose the dura and the nerve root. It's more bloody than the UBE. But the same steps, we will expose the dura and we retract here and here we have the disc herniation. We have here the disc herniation. And we will do the same, we will resect this herniation. Yeah, after opening the ligament, this is the disc herniation. We'll remove this herniation, a huge herniation. We complete the resection of and we did discectomy. And at the end, the root is free, no compression. We did hemostasis. As usual, we did hemostasis. Okay, and at the end, the nerve root is free. And the patient was discharged the 1 day after. This study highlights the efficacy of UBA technique for lumbar disc herniation and demonstrates superior outcome over classical open discectomy. The UBE approach is a dual channel design, provides a broader field of view, enhanced opening visibility and flexibility, and reduces muscle damage. However, this technique has a steep learning curve. Despite limitations such as a small sample size and short follow-up, it represents significant advancement in minimally invasive spine surgery, offering a promising alternative for lumbar disc herniation surgery. And maybe future multi-center study with larger cohorts and longer follow-ups are needed to validate its long-term efficacy and safety. And thank you for your attention.
Well, amazing presentation and amazing pictures, amazing videos. I have the same question for you, and I want you to elaborate a little on that doing both techniques. Number one, what do you see as advantage of tubular versus endoscopic? And number two, how do you personally choose which patient is going to get one version or another?
Good question. The patient choose the technique. I
Okay,
expose
great answer.
for the patient and the patient choose. And for the UBE is more expensive because the patient should buy some instrument, single-use instrument, more expensive than the tube. And personally, both techniques are equivalent for results. No difference, but maybe I am familiar with microscope more, and the time is very short for tube and for microscope. But also maybe with increasing the number of the UBE, they will have the same time maybe.
Would you elaborate? I mean, these are true consideration. I mean, many times we go to conferences, we talk only about the medical side of it, but additional cost, additional time in the OR,
Yes.
we should always consider that. Do you mind to say that compared to the tubular, endoscopic is 50% more expensive, 30% more
Yes,
expensive. How much more expensive it is, as well as you say it is longer to do endoscopic than tubular. I mean, I do tubular all the time. I know it's very
yes,
short
yes.
and effective. How much longer, I mean, the cost and the time when you do it endoscopically?
The cost is the double of the tube.
Double. Got it.
Double, yes. But the time, yeah, the time, maybe the double also. Double
Okay,
time.
okay. Well, and that's a fair statement. I think lots of experience of other surgeons as well reflects your what you just said. That
Yes,
it's very clean. It's a very small. It's a beautiful surgery, but
yes,
we should always consider that it is our additional cost, especially for the
yes,
patient, and
yes, yes,
additional time involved in that. Now, I have two technical questions, and I'd like you to elaborate on that. We saw how in the endoscopic how clean your field was.
yes, yes,
And now, and I know that that sometimes endoscopically, if you don't consider certain principles, the field is not as clean as you just showed us. But what
yes,
do you use? What technique? What tips do you have for somebody who start this process to keep the field as clean as your field was? Number one. Number
mhm,
two, many of us who do tubular surgeries and so on, we have our own technique to keep the drill safe. Like I saw you're using a coarse diamond
mhm.
for
Yes,
your drilling. So
yes.
number one, how do you keep the field clean? Number two, what tips do you have for people who start that when they're using a drill to keep the drill safe? Please go ahead.
Mhm. Yes, for the drilling, there is a protection for the drill. But if we use diamond drill, no problem with diamond. We should use only diamond drill. Me, I use only diamond drill with or without protection. No problem. But with only diamond drill, we can with good drill we can achieve our target and our for the field is very clean. The saline because of the saline. If we use appropriately the saline, the inflow and the outflow, I use without pump with the gravity. Will be clean. The field will be clean, and maybe with maybe because I have the endoscope, the good endoscope,
Yeah.
the last generation with the 4K image. Maybe the field is very clean, I think.
Now, very good answer. And as well, like Dr. Musa said, and I really like that, the gravity the flow does the both
Yes,
for you. You see, the intravenous, most of our bleeding is venous bleeding in the
yes,
surgery.
yes,
And the
yes.
venous pressure is around 12, maximum 15, 16 centimeter of water. And as
Mhm.
well, by, and Dr. Musa was saying that keep the gravity at 50 to 70 centimeter. Is that as
Yes.
well the level that you keep your irrigation?
I keep it at 80 centimeter.
Okay.
I keep it more high.
And I think that is a really key to keep the venous, even if you have a venous bleeding, by keeping the pressure at somewhere between 50 and 80, you're practically, the venous pressure stops, venous
Yes.
bleeding stops by that.
Yeah.
But as well,
Yes.
I think, considering the intracranial and intradural pressure, usually
Mhm.
is about as well about 10 to 12 max. That as
Yes.
well, I have the feeling, but you tell me if it's correct or not. That sort of pushes the dura a little away from you. That gives you a
Mhm.
little more working space. Is that a fair estimate?
The
The pressure that you create with your gravity,
yes. Yes. Yes.
that if it is between 50 and 80, it's much
Yes.
stronger than intradural pressure, so it keeps the
Yes.
dura away from your field. Is that a fair estimate?
Yes. Yes. It's much yes
Excellent.
than the intradural pressure. Yes, I agree.
Excellent.
Yes.
Well, but this was an amazing talk. Thank you very much.
Thank
If
you.
anybody else has a question, please go ahead, ask your question.
Thank you.
Thank you for amazing talk, amazing videos. It
Thank you.
will
Thank
be
you.
all online on our channel, and we will share the link to you.
Okay. Thank you very much.
So, if there is no question today, I want to have a quick conversation. In the last meeting, I did give a talk about the transcamin approaches. Today, I do not want to repeat that. I want to give a small talk about the brief history of spine surgery, different method, advantage, disadvantage of different lumbar fusion surgeries. Obviously, we had two fantastic talk about the endoscopy, comparative, the results, and so on. But today, I actually like to talk a little about the history of different approaches for spinal fusion. Please tell me if you are able to see my screen.
Yes, we see.
Okay, so let me actually put it on a different window that it makes it easier for me to maneuver this. So let me just share my screen one more time. Okay, so the history of spinal fusion has been a bumpy one. As a matter of fact, we have started doing lumbar fusion for almost, we are closing to 100 years. And I think anybody who have been familiar with our historical data, our results were not really good. Spinal fusion were, I'm talking about surgeries that used to be entire day. And many of these patients, by the time they could really walk after spinal fusion, they had no muscle to walk with. The historical data says that some of these patients, what we would do, we would take, and we started it anteriorly actually, because most of surgeons, they were general surgeon. Before we had orthopedic surgery, neurosurgery, and so on and so forth, the surgeon were people who were trained in that general surgery, and then they would specialize in one area or another, and they were familiar with the anterior approach. So what would we do? We would take a little piece of hip, we would take the disc out, put it there, and then put the patient in a cast for God knows how long, sometimes up to a year or more, until the bone grows. And these patients, they weren't really in good shape. First, in 1950s, we started unifying these approaches with posterior lumbar interbody fusion. Again, what we would do, we would take a piece of, iliac crest or cadaveric bone. We take the medial part of the facet off, and then replace the disc. And then again, we didn't have really instrumentation as we have now. We would put the patient in a cast and just immobilize them for a long time. And again, this was the standard of care. This was how we would used to do these surgeries. And first, and now lots of people talk about TLIF, and still more than 75% of the surgeries in the United States, spinal fusions are performed as a TLIF. First in 1980s, we started taking the entire facet off, and that is Dr. Harm in Germany. By the way, he's still alive in his 90s in the city Heidelberg that I did my med school. And what I need you to know that when Dr. Harms described the TLIF, it took about 15 years for our societies, for our colleagues to really accept that. So the acceptance of any new system, any new kind of way of surgery has been traditionally very long. What was the problem with PLIF that TLIF solved? In PLIF, what we noticed, it works well for lower lumbar spine, but when you higher up you go, the rate of neurological deficit becomes tremendously higher. And now we understand that, especially when you go higher up, when there is a cord and TL1, L2 and above, our spinal cord doesn't really tolerate retraction very well. And that was the problem. PLIF would rely on significant amount of retraction, whereas in TLIF, we take the entire facet off, and then that reduces the need for retraction. Now, I'm a neurosurgeon. I'm just going to confess something. A sin of neurosurgeon is that when I learned this procedure, I learned practically PLIF. And for a long time, I called it mini TLIF, meaning instead of taking the entire facet off, I took about half of the facet off. Practically, literally, technically, I did a PLIF. I just called it TLIF. This is my confession. So there is nothing like a partial TLIF. Either you take the facet off or you don't, and that defines if you're doing posterior lumbar interbody fusion or transforaminal lumbar interbody fusion. So I sort of, in a way, I was fooling myself believing that I'm performing a less traumatic TLIF, but not by not taking the entire facet off. And I want as well let you all know that another confession is that we neurosurgeons, we are very adverse to neurovascular structure and injuries to them. So more or less, but the way I learned that is that taking a high-speed drill, and some of our attending even, they would use a coarse diamond, and then they go layer by layer, taking the facet off. And that is a very long process. First, I learned it from our orthopedic colleague that you can use a chisel, and within 15 seconds, you take the facet off, as it was described by Dr. Harm. And as well, that is probably one of the reasons that TLIF, it took so long to really establish itself, because people who start doing that, they weren't really impressed how long it takes to take the facet off. Now, ALIF was always practiced from long time ago until now, and it's a beautiful surgery. But I'm going to move forward a little here and show you the visualization of how these surgeries are performed, PLIF, TLIF. And then in about 2000, we started, but by Invasive, we started taking the lateral approaches. I will come back to that. It's a beautiful surgery. You put a really large size cage, but you have to go literally through psoas muscle. And it's a transpsoas approach, as you expect. And as we know, the lumbosacral plexus is within the psoas, and it is especially at L4, L5 even. L5S1 direct lateral is not really possible in a traditional way. But even in 4-5, where you have the maximum of the lumbosacral plexus, there are some studies they recite 50% rate of nerve injury. So I started doing that, and after a handful of 4-5s, I quit doing XLIF for that level. And that sort of limits that. If you cannot do it L4-5, 5S1, where most of the pathologies in the spine are, it's a beautiful surgery, but it doesn't really apply to where you need to go. Now, ALIF is a true, very beautiful surgery for 5S1, and it becomes harder as for high you go. And that is where it was the birth of OLIF ATP, OLIF anterior to psoas. Now, obviously, the transcambine approach has been described by Dr. Parviz Kambin, who practiced in Philadelphia as well in 1980s, but that really didn't get acceptance in the United States. I don't believe it was like any malicious kind of thing. It was the technology wasn't mature enough at that point. But surprisingly, this transcambine approach went to Asia, Japan, South Korea, China, and actually blossomed there. And everybody in the United States who's talking about endoscopy, that they have been starting it in the last 10 years and they are proud of themselves, we are re-importing it from China, South Korea, Japan. And so they have a lot more experience. Even our colleagues in India have tremendously more experience with the endoscopic. I have never seen so many versed endoscopic. Just before this meeting, I was in a meeting with Dr. Munshi Shiraz Ahmad in Ahmedabad in India. I gave a talk there, and you would see that people from around the world go there to get trained. So even our Indian colleagues are ahead of us here in the United States. Now, I'm going to just move forward here and show you another anatomy. So we talked about all different approaches, and I want you to understand, do you see that very small window corridor between the posterior muscle and anterior muscle? That is the corridor for transcambinolef. But that's not the only one. We as well use with the same technology a transpsoas approach that uses the same technology. We go a little more lateral. We are in the retroperitoneal space. And we do practically for the last 7 years so-called prone laterals. That's a big term now. It's very fashionable term here in the United States. And because we are aware of, if you do a lateral approach, you have to put the patient in a lateral position, decubitus, finish one surgery, break the field, turn the patient prone, and posteriorly instruments. There are some techniques to do it only laterally. I did a handful. The failure rate was really high. So I quit doing that and I did additional posterior instrumentation. But that makes the surgery a long surgery. You do 2 surgeries. The advantage of prone laterals is that you don't have to reposition the patient. Some people who are doing it in the lateral instrumentation, they use navigation and so on, but it is an awkward position. I'm going to show you some pictures regarding that. Now, why MIS? I think I don't need to explain to this team why MIS is important. It is not about the skin incision, about what happened under the skin that makes this patient be able to discharge same day, as you have just both of you have described. And the recovery is amazingly shorter. Yesterday, I did the transcambin 2-level OLEF fusion in my surgery center. By the time I was done with the second surgery, the first patient was discharged. I wanted to go and take a testimonial. We podcasted the surgery to India. I wanted to go and get a testimonial of the patient, but patient didn't even want to wait for me to finish my second surgery. Patient was gone. And I'm talking the surgeries that are extremely efficient, the surgeries that take less than an hour and a half for multi-level fusions. And again, it's not about the skin incision. It's what happened under the skin that makes the surgery safer for the patient, lower risk of infection and similar injuries. That we don't have to cut all those muscle that turn into scar after regular posterior surgery. That we don't interrupt the autoregulation of the muscle, and as well that we don't literally destroy the vascularization of the bone that is provided by surrounding muscle. In a regular posterior approach like TLIF, in a traditional way, you're taking 75% of the vascularization of the vertebral body away. Those studies are well known. And that is the result of a regular surgery. This is a patient of mine in 2012, regular surgery in 2-level TLIF. 2 years later, adjacent segment OLEF. In 2016, then patient had a car accident, broke the hardware. I had to take the patient back. That's how this picture comes to be. And you see where I did the regular surgeries, avascular scar, and where I did the OLEF, it is truly pristine tissue. That helps the patient to recover much faster. This is as well another patient where I did a 1-level TLIF, and even 2 levels above it, multifidus muscle turned into scar. So you're doing not only segmental damage, but we are doing a global spine damage by stripping the muscle of the bone. Now, efficiency is important, and I'm really thankful that you explained to us that endoscopy takes longer. Now, in a healthy patient, it doesn't really matter much, but we have to know about that. This is a study, 400,000 patients, about 400,000 patient meta-analysis, all patients, including prone and supine. Just the time on the anesthesia is a risk factor for the complication. I'm going to repeat that. Just the time patient is under anesthesia is a direct correlation between that and any kind of complication you can think of. As a matter of fact, for prone patient, that correlation is even worse, but generally every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery, to a point that If you put all the surgeries under 2 hours in one group, all the surgeries above 2 hours in another group, you're doubling complication rate. Now, let's go over some of these approaches. ALIF, beautiful surgery, one of my favorite surgeries, but what you need to know, ALIF is the access surgeon surgery. I mean, in some countries, especially in India, lots of spine surgeons are doing their own approaches and they get really good at it. United States is not like that. I know less than a handful of people who do their own approaches for ALIF, not because we cannot do it, we are surgeon, but it's because of the medical legal situation. And that sort of take the surgery from the realm of the spine surgeon away, put it in the realm of the access surgeon. I have had access surgeon that in 25 minutes give me a beautiful approach, and I have had access surgeon who take 3 hours to give me access. That makes renders the surgery irrelevant. If your access surgeon need 3 hours to do the surgery, that give you the approach, this is not really, you're not going to get any benefit of the surgery. And look at the anatomy. There's a very crowded anatomy. And by the way, this is the textbook. In reality, this is cadaver. Now all the blood is gone, huge, beautiful, big approach. In reality, it's even much more difficult than that. It's a prime location with lots of vital structure. So ALIF is one of those things that it either goes beautifully, very well, or it goes catastrophic. Obviously, thanks God, those catastrophic things are extremely rare, but they are not as rare as you think they are. So you have to have a good rapport with a good access surgeon, or you be very worse. And like any other surgery, it's a learning curve to that and so on. You all understand that, but do not take that as a lightly that that is an easy approach, easy surgery and so on. It's all dependent of how the approach goes, and certainly BMI is especially very limiting factor if you're going to do ALIF or any lateral position approaches. Now let's talk as well about some other procedures. Now, by the way, the vascular injuries, this is what you end up with. You have to do fasciotomy to save the leg. If you start doing ALIF and then all of a sudden you have a vascular injury, you cannot even do your surgery. You have to spend all day long to revascularize the patient. By the time you have revascularized the patient, legs start to die and you have to do fasciotomy to save them. So just so you know, it's not all walk in the park and piece of cake to do this ALIF or any of the anterior procedures. Now, the so-called, obviously, PLIF and TLIF are still a standard of care in the United States, meaning by number, mostly these are the procedures performed. We are all familiar with that. And I think the advantage of those is that we learn it in the residency. We get really good at it. I think that's a strong point, very strong point, that it doesn't matter what procedure you think is best for the patient. You have to do the procedure that you are good at, because at the end of the day, it's your complication rate, your risk profile is what really matters. So we are not going to be able to dismiss PLIF and TLIF. Still, even though there are 70 and 40-year-old techniques, we are not going to be able to dismiss them for a very long time. Now, and the TLIF, actually, I think this is the procedure I learned in the residency. By following, you can get really good at it, and your learning curve become really efficient, and then you can do a one-level TLIF in 2 hours. But I think anything trying to do that cutting corner, anything tried less than 2 hours, you're really pushing it. It has a natural kind of profile, and the advantage is you do a direct decompression, and but you have to go through the tissue. You have to respect the anatomy and so on. So I think the natural optimum of TLIF is between 2 and 4 hours, and all the studies in the United States shows that average TLIF is about 2.5 to 3.5 hours. So I'm not going to go through the all the risk profile of what I need you to know when I'm describing other minimal invasively. I'm comparing it to TLIF because by number, that is what you see. You know, there's some studies that they say the TLIF dural tear is 10. Some studies say 1, but if you combine them all together, it seems to be like 7.8%. Nerve injury 1 to 5%, but and so on and so forth. So keep some of these numbers in your mind when we talk about the more minimal invasive approaches, okay? So let's go back now to TLIF, to so-called MIS TLIF. Beautiful surgery. The problem is there, you're performing the same surgery with a smaller opening. That's what MIS TLIF is. Because you have a smaller opening, you cause less damage. But because you have a smaller opening, you're crowded, so learning curve is higher. And as well, practically, when patients have a higher BMI, this becomes truly very difficult surgery. So, and let's talk a little about lateral approaches, okay? And in that, I include XLIF, LLIF, and my method of minimal invasive direct lateral interbody fusion. Now, obviously, XLIF and LLIF are traditional lateral position, but they are so-called the prone lateral now. But MIS DLIF is only in prone position. So it's practically prone lateral that we have been performing now for 9 years. And we have a few hundred cases under our belt. And it's a very good approach. Now, I'm going to again go through the anatomy here a little with you. And these lateral approaches, XLIF and LLIF, the advantage is you put a big cage. The MIS DLIF, MIS direct lateral interbody fusion, we use the same cage like the OLIF. It's a smaller cage. So what's the disadvantage is that the cage is small. The advantage is you have to pass a smaller page through psoas muscle. So the rate of nerve irritation, nerve injury is tremendously lower, number one. Number two is it's done completely in prone position. You don't have to reposition the patient. Patient is prone. Number three, because of the smaller disc cage profile, it's easily done in L455S1, no problem whatsoever. We have published a paper. I can put the link in our talk. So, and here, that is what I was talking about. Imagine you have to pass a big cage through all this structure. You understand that all of a sudden it makes sense that in L4-5, the rate of nerve damage, irritation is, I mean, really, really high. So let's talk about the, this OLIF procedure now. And here you have a visualization about how this progression is, where these approaches on the skin look like. And one of the things I was talking to you about that very fashionable here in the United States is so-called prone laterals. This is, now papers are coming out that Uribe has published and so on, but most of the people who have done that, to my best knowledge, are limiting it now because it is a very technically challenging and awkward surgery. And the reason for that is, look at the retractor system, look at the ergonomic of the surgery. Just that retractor system that you perform prone laterals is two big set just for the retractor system. And you have to be very familiar with the anatomy, and you have to just really rethink that. And as well, look at that again, the patient is prone, but surgeon is sitting down. And I think all of that problem we don't, this is the retractor, by the way, we don't have with the MIS DLIF. Now, OLIF ATP as well, a beautiful procedure. This is the risk profile. Take a screenshot. We don't have too much time. I don't want to go through individual, but it's a beautiful surgery. It's done in lateral position, and the cage size is very comparable to XLIF or ALIF. And here you see the approach. It is a very good surgery, except in L5S1. In L5S1, I still believe that ALIF is a better surgery. And here you see why. The Olif ATP becomes a much better surgery for mid lumbar spine than it's for L5S1. And obviously, since patient is in a lateral position, as well, it requires repositioning. Now, let's talk a little about the transcambin Olif, the procedure that I am very familiar with. And but I want you as well to understand, I describe all the other, like any other procedure, it has its own risk versus benefit, advantages, disadvantages. It's a tool, but it's a tool that you cannot miss in your toolbox. It's a single position. It can go from all the way, as a matter of fact, it can go with some modification from all the way mid-thoracic to S1, but obviously in the thoracic region, we don't call it Olif anymore. It's not lumbar anymore. And I think what's important, you get a real-time AP and lateral view, which makes the surgery really safe for you. It utilizes the Cambin triangle, as you see here. By the way, in the MIS DLIF, you are going anterior to the nerve root, whereas in the Olif, you go posterior to the nerve root. This is distinction between two methods. And here as well, you see the transcambin approach versus a subpedicular approach. This is mostly for endoscopy. And this has been now significantly described. There are lots of papers coming out, one from my good friend, Dr. Elbar in Duke, that he described, he coins the word Cambin prism, rather Cambin triangle. So to really talk about that, this is a three-dimensional structure. And here is, you see that again, the combination of the nerve root and the window you have. So just in the last 5 years, our knowledge has tremendously improved regarding the anatomy of the transcambin approach. Now, obviously, the Cambin triangle has been described by Dr. Parviz Cambin in 1980s. But first in 2010, a group of doctors who are all good friends of mine started doing this procedure, for a fusion. And later on, they tried to use the endoscope. And meanwhile, if it is a fully endoscopic procedure, meaning that you go there, you look at the nerve root to avoid it, so you don't put the hole in it, it's coined CALIF. If you don't use endoscopy and you do 2 CR and neuromonitoring, that is the full Olif procedure. Some other people call it endolif and tubular TLIF, but it's a misnomer, because if you don't take the facet off, you're not transforaminal. If you're extraforaminal through transcambin, I think you should either call it CALIF if you use endoscope, or OLLIF, oblique lateral posterior lumbar interbody fusion, if you're not using endoscope. So, and this is, I think, a good comparative study about where is the strength of each of these procedures. Again, take a screenshot. I don't want to go through all of that. I think most of that should be known to you. That what I like about the Olif, once you go through learning curve, it's really universal. You can go all the way from T7 to S1, whereas I don't believe anybody will do a L5S1 XLIF or L1 to ALIF. Now, that is another advantage of TLIF that is pretty universal as well. That is now, I want to guarantee you, nobody will do a PLIF in the lower thoracic or even upper lumbar spine. It's just not a good surgery for that location. So I'm going to just stop here. And I think I gave you a good predisposition about what these surgeries are. If you're interested in the actual technique, just an hour ago, I gave a talk in India about the Olif technique, some videos and so on. It is online already on our so-called Avicenna Society area. And I'm going to share the link to that talk here with you. By the way, this is the link to our current talk that I'm going to share with you. But in the same channel as well, you will have access to the my previous talk that was just 1 hour ago that talks about how we are going to be able to do the actual transcambing OLEF. So thank you very much. This has been really great to have you on board, and I am happy to answer a few questions if there is any. But I put the link to this talk already in our chat window. So you can, now we are going to do a little light editing on that, and then it'll be on our regular channel for the broader spectrum of people. Thank you. Okay, Dr. Alitr, I don't see any question. I think that sort of concludes our talk today.
Yes.
So Dr. Altier, I don't see any question. So I think that concludes our meeting today.
Okay.
Okay, thank you very
Okay.
much, everybody.
Thank you.
Thank you.
Good